So we're over here, living over here, so we can, back to the business plan. That's good. So this, what I thought we'd do, let me introduce some of ICR, some of our team. Dr. Rob Miner, some of you know, has been here with us. He's in the back, probably doing a caricature of me. Interventional cardiologist. Dr. Steve Hoadley, another interventional cardiologist, is here with us at least for half a month every month. Mr. Tom Maley, who's one of our PAs that works in the cath lab with us directly, and Danica is a RN, also cath lab nurse. Did anybody else from our crew come up? Not yet?
Yeah.
So, and someone will maybe filter in as they come in, but you'll get to see them, especially when you come in through the, as Jeff said, come in through the side door directly to the cath lab. All right, so what there's a whole series of things that Jeff and Dave came up with that we want to go over. And they said to start with the basics first. And some of this, if it starts to get boring or you know all this stuff, just start raising your hands and I'll move on to something else. And I want to point this out right here. So whatever I talk about this evening, this is a much, much better webinar on EKG interpretation. This is done by Todd Moore. He did it for the American Heart. We used it in a lot of places that we did some of the teaching. I know some of you were here, your directors were at up in Polson when we did it down in Anaconda. It's a two-part on EKG interp with I think he's either talking on it or, yeah, he's talking on it. There may not be subtitles, etc. He doesn't speak French or anything. It's just, And he was a paramedic first, and then works as a PA in the emergency room in Butte. And he did a very nice job on that. So I would encourage you to look through that because that's going to be much more extensive than what we're talking about. All right, so we're going to go over basic EKG interpretation, and some of the handouts you've got are kind of in the same vein, but it's something worth hanging on to. They'll make more copies. And then the one that I think is more important and a lot, which we can have a whole other hour on, is the mimickers. Is it or is it not an MI? Okay, so why do we do an EKG? Well, you all know this, but when we were doing Mission Lifeline, we encouraged all of the paramedic agencies to just practice doing 12 leads. Now you guys get lots of chance to do it, but you can imagine more than I think, 80% of the EMS in this state are volunteer, and they aren't always on the clock for acute MIs. But look, here are the reasons you should be thinking of doing an EKG. Obviously chest pain, obviously dyspnea, palpitation, syncope, weakness, nausea, and sweats. And you know that women do not have often do not have the standard presentation of chest pain for acute coronary syndrome and MI. So if there's any suspicion, do a 12 lead. Sometimes you'll surprise yourself. So real quick, and I know you guys know all of this, right? Because there'll be a quiz after this. No, there's not a quiz. So, there's atria, there's ventricles, the aorta, vena cava. And the back side is just as important. Everybody gets used to the anatomical front side of the heart, but in the back side there are also some pretty important areas which we'll be talking about as we go through the MI sort of situation. The cardiac blood supply, remember what we're trying to do with an EKG, and I know that it's probably the most perhaps overused diagnostic thing that we use in medicine, but is we're trying to correlate an electrical phenomenon using, well, I'll show you in a second, electrical phenomenon, what's going on in segments of the heart. And obviously we're interested in the segments is what's being supplied and what's not being supplied. All right? So, and I know we've been through this before with segments for MI, and we're going to go over that quickly again, but these are the basics, epicardial vessels that we think about when we're looking at MIs. And of course, the heart is a three-part deal, right? It has muscle function, it's a pump. It has electrical function, and it has circulation function. So we have to think in those terms of all three things that can happen to the heart when you're looking at somebody who is presenting with chest pain, sweating, syncope, or whatever, okay? All right, so when's the last time you used Bachman's bundle? I'm thinking in fellowship is the last time. Anyway, so these are they're not in green really in the heart, but these are the electrical connections that we are always dealing with or we're interested in. The SA node, obviously the pacemaker, the AV node, and its semi-connections through the atrium, obviously the His bundle, the Purkinje systems, right and left bundles. Okay, nothing new. All right, now, this is what I'm talking about when we're looking at, first of all, just limb leads. And Eindhoven sat a guy, was he a bricklayer, I think, sat a guy in a bucket with his left leg in a bucket of water attached with, I think it was saline solution or something, and had electrodes that were copper and some slime on it of some sort. And he came up with this idea of the Eindhoven triangle. And here I can show you that. So this is what he came up with, essentially, and using this homunculus without a head. But basically, right arm, left leg stuck in the bucket of water, and he learned, he figured out, or he started out the idea that you have, limb leads that are in kind of a triangle. And so the idea here is that we start to think of the heart in vectors. So when you hear us talk about vectors, or someone is talking about vectors of the electrical system in the heart, we're talking about positives and negatives. Positive, lead one, positive. Too sensitive, don't touch, sorry. Positive and negative, positive, negative from the angles that were set up long ago. Why is that important? Because I'm going to have you start thinking about looking at leads as if you're an eyeball from the positive side, looking in one direction. All right? So, there's the triangle. So, this is a 12 lead. Obviously, you've all seen 12 leads. This is the most normal 12 lead I could find. And it has different aspects that we're going to go over. You need to look for certain things on a 12 lead when you first start. I know everybody wants to first look for the VTAC. Okay, fine. Everybody wants to see if there's an MI going, and that's good, because we're looking for ST segments. But as you get more sophisticated with looking at EKGs, and we talk about more of them, and we start doing our arrhythmia sessions, for instance, you're going to need to be able to start looking for certain things. Is there a P wave in front of every complex? Is the complex a narrow complex or a wide complex? Does it have a normal T or an ST T wave complex or segments, which we're going to go over? And is the vector correct? And there's that term vector again. In other words, is it in the Eindhoven triangle, is it actually coming from this direction down toward the left leg, and on the precordium, which Eindhoven never looked at, is the electricity going toward the left ventricle? So these are lead placements, all right? Now, I'm going to go over this because you would be surprised, maybe you wouldn't, about how many times we see a patient come in, not from your crews, but from other places sometimes, or even in our own unit sometimes, where the leads are in the incorrect places. And why is that important? Well, it's important because you want consistency. So if they're coming in and the leads were placed too high, let's say, and then they get into the unit and they put them in the right place, then that's going to look like a change on your EKG, which we don't want to see changes on the EKG unless they're beneficial. But this is where we're talking about on the interspace for V1, V2, V4 is below the nipple. Women, if it's at all possible, I know we've had this conversation before, you can't put V4 on top of the breast above the nipple. All right? One, it'll be in the wrong place. So you'll need to lift the breast out of the way and put V4 where it belongs. V5 and V6 along that same interspace, along the rib. This is one of the better examples of where V4R needs to be placed. Why do we have V4R? Right ventricular MIs, exactly. So there's times, now, that's not the first thing I want you to do when you put up your 12 lead and you transmit, but this is something to think about. When you're not seeing the ST segments and you look at this patient, you're going, gosh, sweaty, can't breathe, maybe it's a PE, but you know what? She's having the chest pain that sounds an awful lot like an MI. Let's put a V4R lead on here, or we'll even talk about posterior leads down the road. I don't want you to hold up, getting the patient into where they belong, but the idea is to teach and to learn a little bit about what we're trying to do. And I noticed that the American Heart, from where these come from, nix that out, and I'll show you why that is. Here is where the lead placement is supposed to occur. I'm going to encourage that if there's time and time to do it, if you put leads in a certain place, do they carry permanent skin markers with them?
They, usually not.
All right, I'm trying to get the CCU people and the PCU people for them to start to actually mark where we're supposed to be putting leads on, so we can see that they put them in the right place. So this is the classic lead view. All right, we already talked about these, and out on the wrists and down on the ankles. All right, that's the classic position for limb leads, etc. However, that doesn't help us much. And as each of you know, that if you've got people who are moving in the ambulance, in the rig, and this does not make for a great baseline for your EKG, because there's a lot of movement when you're moving people around, or they're moving themselves around. So this is an example of where they need to be and why it's helpful to us. These, of course, are in the right position. V4 is where it belongs, V5, V6. Here is where, I didn't even touch it, but here is where we would like to have the limb leads placed. All right? And what you don't see is underneath his belt is that there's another one here and another one here. And why? Because when we bring them to the cath lab, this is where we're going to have them, in these positions. And is it a big deal? It's not a big deal. I mean, when Eindhoven did his usual, he actually is talking about the proximal portions of the leg and the proximal portions of the arms. So this is kind of the setup that we should be trying to achieve here, because it helps us without having to replace everything where they need to be. All right. Now, here is the vector situation as far as precordials are concerned. All right? And we've chopped the patient in half, right, left, posterior, anterior, and this is the major electrical vector. Awful sensitive. This is the major vector that you see going from right to left, and there are the precordial leads, V1 through V6. Notice that V1 is mostly negative, and V6 is positive. That's normal electrical pattern through the chest, all right? And that's important to know if we start talking about, in other sessions, conduction defects and arrhythmias and things like that. So, now why is that important? These are some of the intervals that we talk about. We're going to skip that. So let's quickly go over this. What do we mean by an R wave? What we mean by an R, well, okay, you all can read. So the R wave is the positive deflection from the baseline until it reaches baseline again. R wave. Not all leads will have an R wave. Q wave. The Q is that component in the first negative deflection coming from the baseline down until it comes back to baseline. Not all leads will have a Q. Some will have a Q and some will not. J points. And J points are important because of our whole discussion we're going to talk about with acute MI. The J point is when the R has quit or has come back to baseline, and it's that segment where it makes a sudden deflection before it gets to the T wave. It's important to know where the J point is, and because that tells you when your ST segment starts. And these are all important because one of the things you guys are looking for are ST segment elevations, correct? Or depressions, all right? And now, ST segment elevation or not. This is related to a comparison to what's called the TP segment, or what we just call baseline segment. Between the T wave and the next P wave is a period of essential equi-electric, not quite silent, but equi-electricity within the heart. Everything is depolarized and now everything's repolarized. So it's just quiescent for electricity. There's other things going on mechanically, but that's it. So now that we know those parts, and like I said, if you go to Todd's thing, he goes through this in much more depth, which is interesting. Well, let's go over this is the American Heart presentation, the 3 I's of an AMI, and this is a little bit wrong, so we'll go over it and we'll show you some examples where you start getting peaked T waves first, which is sort of we call hyper acute T waves, which is where the first sign of ischemia comes on. Then you get the ST segment elevation, which is really what we call the injury current. And then when you finally start to get Q waves, then you've already got necrosis setting in. So here we go. This is more correct. So there's the hyperacute T wave. With it's more peaked than that usually. It doesn't look like a bullet. It's more peaked. And then you go into where the ST segments start to follow it up. They sometimes talk about being dragged upward. And then they don't show the rest of it, is that when you start to develop the Q waves, that means tissue necrosis is coming on. And then there's an evolutionary portion, which after that has happened and the MI is completed, or we've sometimes reperfused them, then the T waves will flip over. And that is a normal evolution of an MI. So the very first thing that you may see when you go to pick up a patient, depending on how fast you get there, and you guys are pretty fast, is that the chest pain may have been waxing, waning. When you get there, maybe they're not quite so much chest pain. They may be where you're only seeing is the hyperacute T waves, the very peaked T waves. Don't be fooled by that. And don't wait for the ST segment to start elevating or coming up. All right, so let's look at some. Oh, okay. You guys know what to look for. For an accurate EKG, oh, that's right. So when the limb leads don't get placed correctly, that's when you see things like the AVR is positive and looks like lead 1. Right? The first thing you should think is not that the patient has an upside down heart, but the first thing you should think of is that the limb leads are not placed correctly. All right? So, and then if you need to, we'll go back to the original EKG, the normal 12 lead that I had, and you'll find that the AVR should be mostly negative. Everything should be negative in that lead, in that AVR lead. One complete cardiac cycle has to occur in each lead cycle, and it should be done at an appropriate speed. These are the things that can confuse any ER doctor, not us, but any ER doctor when the thing gets transmitted at the wrong speed. There's no ER doctors here, right? So there's only 5 minutes left in the meeting, huh? Let me get rid of that. So, practice. Let's look for J points, baseline and ST segments. Well, everything's pretty much lined out for you there. Where the green line is what we call kind of the baseline, the T to P baseline. The J points are in a gold circle or yellow circle. And you can see how it's important to know what part's the J, because that defines what the ST segment is doing. And underneath is just some examples of foolers. Obviously, no and yes means no, the ST segment is not elevated. Yes, it is elevated. No, that one in the middle that says no, this is, I'm afraid to touch it, but this is, that's a bundle branch that is not an ST segment elevation. Okay, and we'll look at the differentiation here. And yes and no, that's obviously a ST depression. All right, so here we go. Now, how many have gone through I've forgotten how many went through the talk that sometimes the American Heart people give about identification and grouping, continuous leads. Have people been through that before? Is this boring? Is this? What we do is we start looking at patterns at 12 lead EKGs for MIs. And what you see in front of you is sort of and I'll put this here, let me go to here. It's looking at a 12 lead in groupings. And the groupings go along with where the MI is occurring. Remember, at the very beginning I said the idea is to correlate and the EKG changes with a perfusion territory. Which coronary artery do we think is in trouble? So in green, which is the easiest one of all, is all in the limb leads, 2, 3, and F. Would be where you see your inferior MI occur with the ST segment elevation. The V1, V2, they call septal. We're going to go over those. V3, V4 is anterior, lateral is 1. They left out AVL, but 1 AVL and V5, V6 is in the lateral. And that has all to do with that vector thing that I was showing you before. So if you look at localization, the green is 2, 3, and F, and that's the inferior MI. The bright blue is septal, so it's sort of in the middle compartment, middle wall of the heart. They don't always happen just segments like this, but this is the way to start thinking about it. And then the anterior ones are V3, V4. Now I'm going to show you some examples where the anterior heart attacks don't occur just in one small area. They usually drag in the septum, the apex, and as well as the anterior wall. So this is just a way to help you localize by grouping leads. And there's the inferior wall. And again, it's showing that the camera, remember I talked about positive and negative? So if you think of your eyeball as a camera, at the positive, you're looking up at the bottom of the heart. Therefore, the ST segments, did they give an example? Here you go. The ST segments are positive, are elevated in 2, 3, and F. Okay? That's not a bundle. And how do we know that it's not a bundle? Because in the other leads that are not being affected by the MI, the QRS is not wide. All right? But that is a nice big elevation. The T waves have already peaked. See, they're still up. Now it's dragged the ST up. So this is an inferior MI going on. And what are the other, let me see who's been paying attention. So what are the other clues we look for that this is a true ST segment elevation MI? Well, remember, every time there's a positive that you're seeing a positive effect in one lead, you're probably seeing a negative effect in a different lead. Well, we call that reciprocal changes. So to really know that it's an ST segment elevation, that it's ischemia going on, injury going on, this is called the injury current, you look for the negative changes that should occur, the reciprocal changes. Think of the heart, and that, remember the vectors all through the heart, like a voodoo pin doll, right? So anywhere that there's positive, then the leads away from that should be reciprocal. And that's a typical pattern that you'll see. So reciprocal changes in these leads and positive changes in the inferior where the ST segment's going on. All right, let's go to the next one. Anterior wall. Now they're only using V3 and V4 here, but I will bet you that this is going to be more than just those leads that have ST segment elevations. Once again, the camera is looking from sort of the anterior chest here. So these will be your positive eyeball look. And you should see, therefore, positive changes that are occurring in the anterior leads. And they're going to pick V3, they threw in V2, V4. But if you look around, look at V5. That's not a normal. I mean, that J point's elevated, right? And the ST segment's already up. And you'll probably say, wait a minute. I see some ST segment changes in 2, 3, and maybe even F. So is this an anterior and inferior MI? Could be. But more likely, it's a big LAD that's anterior and it's wrapping over the apex of the heart. So remember, the EKG is just a camera. It's just a look-see. So when it sees injury from the anterior over the apex, it's just going to pick up anywhere that it sees injury current. And there's some reciprocal changes. Not much on this one. Not much on this one. Okay, septal. Septal, the camera supposedly is right directly over your sternum, looking straight into the heart. And they give you this example where V1, V2 shows the J point elevated up with the ST segments dragged up by the hyperacute T. But look at V3, look at V4. Those are not normal either, all right? So it's not unusual to have these other areas that have hyperacute Ts and ischemic changes. Lateral wall. And using this example, this is not a great example because you can see ST segments occurring everywhere on this, right, on this EKG. So, you know, V2 is elevated, V3, V4, V5, V6. Look at the elevations down here. So, this is not the best example of a pure lateral wall, but suffice it to say that if you're seeing these changes in the anterior wall, and it involves the apex, that is a big anterior MI. And are there reciprocal changes? Yes, there are some reciprocal changes. That is a big anterolateral MI is probably, or some people would call it an anterapical MI. All right, so what to look for? Real fast, real brief. So you've got your TB baseline, you have your J point, which is already up. You've got the T wave is still positive, it hasn't been flipped over yet. And your ST segment deviation is obviously over 4 millimeters. So remember, an ST segment elevation MI must have at least 2 contiguous leads. In those groupings that we talked about, they must have 2 contiguous leads in a grouping. That's at least 1 millimeter elevation, by one little small box, at least elevation. All right, if you just see it in one lead, something else may be going on. If it's in 2 separate, not contiguous leads, maybe something else going on. All right, so, okay, let's go over acute coronary syndrome. You'll sometimes hear us talk about acute coronary syndrome or a non-ST segment elevation MI. The big thrust now from ACC and American Heart is to get much more aggressive with non-ST segment elevation MI. Why? Because sometimes EKGs don't show an ST segment elevation, but they're still got an occluded artery. Or the MI is being shown only in the right ventricle and nobody did a V4R, or it's a posterior MI and they're just seeing ST segment depressions anteriorly. Unless someone happens to think about putting the leads on the back of the chest, they won't see that ST segment elevation. But here's some other reasons for ST segment depression. Non-infarct ischemia, or so-called non-STEMI, digoxin toxicity, hypokalemia, LVH, and that is an example of downsloping or flattened ST segments. All right, now, there are things that can mimic or make it impossible. Mimic or hide. And your handouts, if you, and that's sort of one that I've used for years teaching CCU nurses, and there's actually some practices in there, and I hope they copied well. It's hard to copy EKGs because of the little tiny boxes in there. But if you'll just take that home and go through it, there are some examples in there that are kind of listed here about things that can either mimic or mask acute MI. And the true aficionado of EKGs, which you all are, or need to be, is to be able to sort out, you know, what's a ventricular paced rhythm, what is a left bundle, what's LVH as opposed to an MI, what's early repolarization. Dr. Miner just showed me one of the best ones that we've seen in a while, or what's pericarditis. But I'm not, rather than go over that, like I said, that's a whole talk on its own, which is actually a very interesting talk. So, using the positive electrode as an eye, we're going to look at these. Here's a practice. So anybody can call it out. If you don't, I'll just keep talking. So where is the ST segment elevations?
2, 3, and AVI.
Correct. So that makes it a
Inferior.
correct. And so to make sure that that is truly an injury current, that's the term we give ST segment elevation, is injury current, is you see reciprocal changes in those leads right there. And you also see them in V2, V3. Here's another one. This is obviously a real one, not computer generated. Same thing, same idea. And it looks a lot like the computer generated because inferiors are pretty straightforward. And actually, this one was called an inferior posterior, and the reason why they're saying that is because sometimes with a posterior infarction, remember, a true posterior infarction, unless you put the leads back on V7, V8 back here, you won't see ST segment elevations. The trick will be is sometimes you don't see anything here, you see a little in V6, but these in V1, V2 are the negative eyeball, so they're going to be depressed. Okay? They're going to be, so here's the MI back here, so here the eye sees negative. It's going to be away from them. All right, here's an anterior. And this is a pretty big anterior. It involved V2 all the way through V6 and includes the lateral leads as well. So this would be a proximal LAD with a diagonal probably involved.
That's a good case of tombstoning.
Correct. All right, let's see what he's talking about. So notice the one that were computer generated in the last couple examples, they just show an ST segment going up with a T. What he's talking about is this almost rounded ST segment up. That's when you hear us talk about tombstones. That is what we're talking about right there. Are there reciprocal changes? Yeah, there are some reciprocal changes. Okay, but that is a big anterior mine. Okay, well there they are. Now the practice. This is nice because nothing is tombstoned yet, but we're catching it very early on. This may be what you see when you get on site. You guys are pretty fast, so by the time you get there, maybe they haven't decided to wash the dog, bring the cattle in, or finish the dishes or something before they finally call 911. So when you get there rapidly, this is what you'll see, is things are hyper acute because they're just starting, all right? But it's real.
What would make you, versus hyperkalemia, would it just be that they're presenting with MI?
Exactly right, exactly correct. So, you look at them, you see them, and if they're not sweaty, not in pain, not gasping, then you're going to have to think the worst.
And age. That's not, you don't see that in a 25-year-old.
Okay. All right.
25-year-olds have the way PCD waves, and they'll fool you.
Okay.
But if it's a 40 or 50 or 60-year-old, no problem.
So and I thought somebody was going to ask, how do we know it's not early? Suppose this is a 30-year-older. How do we know it's not early repolarization? Well, in early repolarization, you don't see this. All right, the reciprocal changes are what tell you the difference. All right. Same thing here, just another real one, practice. Anterior. Now, here, this is real quick talk on when it's happening toward your eyeball, it's the positive changes you're seeing. All right, for the ST segments. When you're on the opposite side and the MI is away from you, it's the reciprocal changes that you're getting. So, and they've just sort of said here, zone of ischemia, zone of injury, and zone of infarction, meaning necrosis. We use the term necrosis, meaning the tissue is dead. Okay, one example. 74-year-old female, sudden onset epigastric pressure, had some nausea. Just pressure, epigastric, not even in her chest. Shortness of breath. But she wisely called 911. She didn't wake her husband. What test should you perform within 10 minutes? That's just right. That's just a guideline. That's a guideline, and they're just trying to make the point about the guideline. And this is this is a real EKG, and this is what it showed. And so it's obviously what, lead 2, 3, and F. And she called fast enough that the team picking her up was actually catching the hyperacute T's at the very, maybe in the mid stages, but there's reciprocal changes, and it was obvious that she was having an inferior mine. So this is what they did. Obviously, she got aspirin, and she got 1 nitroglycerin. Now, what do y'all remember about inferior MIs and nitroglycerin?
You can bottom them out.
Right. It's not that you never give it. I mean, you want to get the patient comfortable. But what are you going to expect to have? What should you have in place before you give them the nitroglycerin? Maybe 2 IVs. Okay, nice big bore IVs. All right, and don't be afraid unless they're frothing at the mouth. Don't be afraid if you get an inferior MI to start putting some volume into them right away. We'll love you for it. Okay, all right, and then morphine. In the hospital, very rapidly, they brought her in to the local critical access hospital, treated appropriately with, they used TNK because it was a distance away. They knew they couldn't get her on the table in the right time. Plavix ahead, Lovenox, anticoagulation transferred. And you see the vital signs. There's the blood pressure. So what do you think about that blood pressure? Should they have given volume? Right? Okay. And became unstable in transport, taken directly to the cath lab. And this is what it showed. So even though the TNK opened her up, and that's a better situation for us. We love it when they get them open and flowing rather than not flowing. It still was not enough. There was a lot of injury going on. I think there's actually clot that actually sailed down into this distal branch down here. But where the arrow is, obviously, is where a stent is. So this is the kind of thing that won you the award. Is first, by the way, first medical contact is now how we are being judged. When I say we, I mean everybody in this room. It's no longer any good for the patient to show up at the door and we start the clock at the door. They're going to start looking at first medical contact when you arrive on scene. As soon as you touch that patient, that's when they're going to start the clock. All right? ER arrival time was 3 minutes. She must have been in the parking lot. No, that's not right. It's still half an hour. It's very fast. First EKG was done in 7 minutes. That's excellent for a critical access hospital. Lytic was administered very rapidly. It's supposed to be done within 30 minutes. They didn't quite make it in the 30 minutes, but they're close, right? And then transfer out time didn't get recorded, and total time in the first facility. These are things that we all won't get measured in town, but this is what the critical access hospitals are being measured. Is how fast they get them treated, how fast they get them transferred out. So,
What did the EF and LOS mean? What is that?
oh, sorry. Length of stay was only 3 days,
Yeah, and the
which
EF.
is good. And ejection fraction is the heart function when done. So she had nearly normal heart function, and that probably was done within the 3 days that she was still there. We often check the heart function quite a bit later on after they've recovered. So never make the mistake that a single 12-lead rules out an MI. If it walks like a duck, quacks like a duck, drops, you know what, like a duck, it's probably a duck. So if it looks to you that they're sweaty, that they are, hurting badly, their pressures are a little bit unstable, even if the EKG doesn't yet show a STEMI, or even ST segment depressions as a non-STEMI, be very, very suspicious. Don't be afraid to just shoot another 12-lead EKG. And we've had plenty of examples. I wish I brought one today, but plenty of examples of where, and we just had one come into us at the Billings Heart Community, where the first EKG looked fine. And they did another one right in the emergency room, and there goes the ST segments. All right? So repeat it in any symptomatic patient. So, by practice, we mean, any excuse to shoot an EKG, do it. And so that we get good at it, and then we'll talk more about them, and you may find some interesting things we can bring to a session like this and talk about them. So, are there any questions? All right, so you have in front of you 12-lead EKG made easy, sort of, and then you've got the mimickers and the maskers. All right? Now, for my colleagues, any input? Steve? Rob?
Yeah, I just want to say one thing. If you look at the death certificates in the United States in the 1920s, before we really understood what heart disease was all about, the leading cause of death was acute indigestion.
Yeah.
So remember, especially if you're seeing a patient that says, I think I've got really bad indigestion, I've got an ulcer, that's almost always associated with either the right coronary artery or the circumflex. Because believe it or not, those arteries kind of share a nervous system with the stomach. And so I can't tell you how many times people said, oh, I thought it was indigestion, I thought it was my stomach, I didn't want to bother anybody, I've had something like this before, and they hadn't included right coronary artery or circumflex. So always keep that in mind. The other thing is that there is one thing we didn't really talk about very much, where an included major artery causes a normal EKG. It's because, remember, as Dr. Waldo was saying, the EKG, all the leads are on the front of the heart. They're not on the back of the heart. So if you have a circumflex that goes behind the heart and is proximally occluded, you will not see that on your front EKG leads sometimes at all. And so, we always kind of consider that. Somebody's in the ED, they're having this chest and abdominal discomfort, their pressure's weird, they're having runs of VT, their EKG looks fine. Can I send them home? They're like, whoa, wait a minute, that could be a circumflex occlusion that we're missing. It's not common, it's pretty rare, but I think the major point was people with acute indigestion, no matter what age, have, in the back of your mind saying, this might be an MI. I'm going to give them a little bit more attention. I'm going to do another EKG in a few minutes because that is so commonly what people present with when they have MIs.
So here's the biggest problem that you, all of you here and we face, right there. Only 40% of the patients call 911 right here in town, where they have a PCI center available to them. We're able to get times to open a vessel in 30 to 45 minutes. That means there'll be, if they call in time and they get them in, and you guys obviously get them in, there'll be negligible heart muscle damage if they would just call 911. Look at critical access out in the rural area, which is the worst out there. They need to be calling before they have their heart attack. But only 20% of them or so actually call 911. And they're often in dire straits by the time we get to them. So anyway, our biggest, if you can think of ideas or marketing or public service kind of announcements, you might get people to start to you know, pay attention, calling 911, please let us know, or let's work on it together or something. Because if they call, we can do a lot for them. Yes, Steve?
Yeah, I'd like to reinforce something because you showed a couple of pictures but didn't actually describe it. And as we had this issue in our own office, and I kind of helped out with trying to correct it. It is amazing to me how many times the precordial leads are put on wrong. But while I'm telling this, find one of those ones that shows the AVR real nice, but you didn't actually show it. Just find one of your EKGs that shows normal. Normal would be the best.
Okay.
But when you're doing the precordial leads, you find the angle of the sternum, called angle of Louis, whatever. It's the bend in the upper part of the sternum. And right below that is the second intercostal space, and you just feel right along there. I can't tell you how many times I've seen people put the leads right there. And they're too high then, and that'll look like an anterior MI, an old anterior MI, but an anterior MI. And then you bring them to the CCU and they put them down here, and it looks like the anterior MI went away or showed up or whatever. So you find the angle of Louis, the angle bump on the top of the sternum. You find the intercostal space right there and go 2 down. And they're on either side. That's where you put V1 and V2. Okay, then you want to get V4. I actually told them this, and it's been so long since I learned it and taught it, I went to the website and found out that's exactly how you say it. It sounds funny, but you find V4 before V3. And V4 is right along the anterior, the mid-clavicular line. Don't use the nipple because it's always different on people. The mid-clavicular line, you go straight down to the 5th intercostal space. So you go 1 intercostal space lower, and you put V4 right there. Okay. Then where does V3 go? Right between V2 and 3. Just exactly how they teach you. Then you go from V4 to the anterior axillary line at the same level. That's V6. Then you say, well, where's V5? Right between V4 and V6. And that's the way you do it, and it's standard, and it'll become second nature to you. But the biggest error I've seen is people putting V1 and V2 right up in the second intercostal space. I guess it's just because you get used to it. You know, your first thing you do is you feel right there and you're in a hurry and they're having chest pain, you go boom, boom. No, go down 2 interspaces. And then just up here, in AVR, because that's the other thing I've seen, I don't know how many hundreds of times, is the limb leads reversed. And he talked about it, but he didn't show an example. Look at how negative that AVR is, okay? If it looks like this one, so you're looking at AVR and it looks exactly like that one, you go, wait a minute, it's positive, what's wrong? Well, there's some ways it could be really wrong, but the first thing you do is you switch the leads, or at least look at them and you say, oh my gosh, I got the left lead on the right arm and the right, you know. And that's not a big, doesn't mean you're a bad tech, it just, because I've done it, and we've all done it, you know, just switch leads.
All right, any other questions?
Indoor-
Yeah, Tom. Oh, yeah. Tom?
My perspective is a little bit different, you know, working in cath lab, but I also abstract all the numbers, so I can do a retrospective looking back at how things really turned out. And surprisingly, one of the counterintuitive results of all of this data gathering is that when EKGs are performed on STEMI patients, you spend an average of 6 minutes less time at the scene. You figure it take longer. But it's actually the opposite. You take less time at the scene if you do a 12-lead EKG on a STEMI patient. And you're not alone with a stunning patient. The machine helps you a little bit, you got crew members, and the other gatekeeper is the emergency room and the cardiologist, those physicians. They look at it and they declare, okay, let's activate the standard team. So you're not alone, and we're working in teams, and this is a system of care. So it's high suspicion, do the best quality EKG you possibly can, because that helps the diagnosis. And just keep going on. Thanks.
Can you just address putting the right, looking on the right side, the actual mechanics of that?
For the right lead?
Yeah.
Okay, so V4R is your best right lead to do. It's exactly where V4 would be on the left side, but on the V4. So it's mid-axillary line. And males, we use the nipple, and I mainly was saying that in women, the nipple is often down here in older women, so don't use that. It's gotta be, you know, mid-clavicular line in the fifth intercostal space, and then you follow around. And the same, and the right side is on the right side, obviously.
Yep.
Thank you very much.